Hi, everyone. Welcome to today's Facebook Live session. We hope you are ready to learn how to be the boss of your blood sugars. So we're about to start here. Just give it one more minute, and then I will turn it over to Dr. Bhargava. And we also have our expert pharmacist, Dr. Jamie Pitlick.
All right. Well, good afternoon, everyone. And thank you for joining us today. It's great to be here with you as always. Excited. You guys deal with these sugars 24/7, and let's show them who the boss is. I want you to be the boss of your blood sugars. And that's really the goal today. I'm an endocrinologist in diabetes since 96, and then as an endo in Des Moines, Iowa since 2002. And it's extremely frustrating to me to just think about this, that in the last 15, 20 years, we had 8 new classes of medications, all these insulins, glucose meters, sensors, all of those things and advances. And what frustrates me the most is the fact that 50% of the patients in the US are still not meeting their sugar target. How is that possible with all these advances? And so our goal is to make sure all these tools are available and help you become the boss of your sugars. Very happy to have Dr. Jamie Pitlick with me. She's a very passionate pharmacist, very interested in diabetes, and teaches at Drake as well. What we're going to do today, talk about when should you check your sugars, what are the targets, and how can you control your blood sugars better. As a reminder, we want this very conversational. So if you have comments and questions, please feel free to ask them. And without much further ado, then I will jump into why. Why should we even do anything about blood sugars? Well, if your sugars are good, you will feel good. If your sugars are 200, you're not going to feel as good. So just very simple. If you know where sugars are, you keep them in control, you feel good. It reduces the risk of complications. I call diabetes the silent killer, the number one cause of blindness in our age group, non-traumatic amputations, and people going on dialysis. These complications must be avoided. And the single most thing we can do in our hands to avoid these complications is to control our sugars. And lastly, diabetes is a team game. On your team, you want the best people, you want the best doctors, and you want those doctors to have the best tools for you. And one tool that they need for your good diabetes management is your sugars. So if you take them there, they're going to give you the right treatment. All right. I think, and Jamie, I just want to actually have you say a word or two before we move too much forward, and I'll let you be an active participant in the conversation. So you have anything to add before we jump on our tirade against blood sugars?
The only thing that I would add is I just think that it is a really underutilized tool. It's a teaching tool to help you learn how your body is working. And if if you use that teaching tool, you can really take control and learn how to take control of sugars.
Thank you, Jamie. Now, again, you guys can put your comments and questions in the chat box. And Jamie and Casey, thank you for moderating and being here. And please ask the question. I'm not able to see the screen because I'm sharing this PowerPoint. All right, a question for you guys. Tell me what your fasting sugar target should be according to the ADA. Less than 180, 110 to 150, 80 to 130, or less than 90. So please type in the comment box in Facebook and wherever you can, and I'll go over this information. So in general, we think about fasting sugars and before meals as one group of sugars. After the start of the meal, and typically we're saying about 2 hours from the start of meal in general, and then bedtime. So those are the categories we want to think about. All right, ADA, 80 to 130 fasting. So understand that 125, 129 may be okay according to ADA, and before meals. ADA says the peak should be less than 180, which is typically 1 to 2 hours after a meal. And then bedtime, 110 to 150. As I said, I'm an endocrinologist. There's also the sugars from our association, AACE. They have, in general, been stricter. So 80 to 110, less than 140, 2 hours after the start of a meal. So 2 hours when it's really coming down, and 100 to 140 at bedtime. Jamie, what do you advise your patients?
I generally go with the ADA. for most of my patients, either saying 180 over 130, or if I like even numbers, I might say 180 over 120 and have 100 be right in the middle for fasting and before meals. But I'm really curious, what do you normally tell some of your patients? Because I know every patient is different.
Yeah, and no, so you brought up an extremely important point. Regardless of these guidelines, work with your doctor on what the target for you should be, because Jamie brings a very important point. One size does not fit all in diabetes. Everybody needs their own targets, frankly, and these are just general guidelines. And I'm glad, Jamie, you asked that. So I do have some thoughts on what I tell my patients. Simplicity is good, so I like to have these even numbers in a sense. 80 to 120 before meals is what I say. And then that's a 40-point difference. So my math, simple math, 80 to 120, and then less than 160 other times, bedtime, 2 hours after meals. That's a general simplification. But please know, simplification can be erroneous. So the most important thing I want to say on this slide is your targets needs to be decided based on age, the medications you are on, and presence or absence of heart disease. Let me explain. If you are older, we are going to shoot for a higher blood sugar target. It's okay for sugars to go higher as we get older. The risk of complication isn't as much because of the duration of life expectancy and so forth, and the risk of lower sugars. So it's a fine balance. If you are on medicine that cause low sugar reactions, insulin and sulfonylureas like glipizide, glimepiride, glyburide, then we shoot for a higher target. If you have heart disease, we shoot for a higher target. So think of this as a general guideline and then work with your provider on what the number might be. Casey or Jamie, any questions or comments we need to take from our audience today?
No questions from the audience yet. One of my questions that I get constantly from patients, though, what or when should you be checking your blood sugars?
Gotcha. So no, that's a great point. Again, one size doesn't fit all. And I, again, want to see what the audience says. If they're checking and once a day versus 2 to 4 times a day or more than 4 times a day. So I think that's another key question. And we'll again go to our guidelines, and then you have the ADA recommendation in between, and then kind of my thoughts on what it should be. And then, of course, we also want to know from the biggest player on our team, the insurance company, Medicare, Medicaid, and all that. So we'll have Jamie talk a little bit about what these guidelines might be from an insurance perspective. At the end of the day, the ADA could say whatever, and I could say whatever. But the important thing is that you ought to be able to afford your strips. And I would like Jamie to shed some light, if time permits, towards the end on some ways of making this more affordable. Okay, so it really depends on how often you test your sugars, really depends on what regimen you are on. If you're not taking insulin, the ADA does not have any specific recommendation. And many people argue that it shouldn't even happen, like don't check sugars. And at some of the European countries, that is the case. My take is if you are on something that causes low, a sulfonylurea, glyburide, glimepiride, and glipizide, then you should check. And megalotonides, which are extremely rare to use, so I won't mention the names. So then once a day is a good idea. Have enough supply, 30 a month or something.
If I can interject just a little bit.
Hey.
The other thing that I would add is if you're not having good control, and you're actively trying to increase your exercise or increase your diet control, I would add that as checking once a day as well.
Makes sense. If you start following an aggressive diet, then you probably need a better monitoring of your sugars. Good point about lifestyle and how that should impact the frequency of checking. Now, many people, when medications are not working, they'll go to a long-acting insulin once a day. In general, ADA says for those fasting sugars. For me, I do like to see paired readings, bedtime and breakfast. So if supplies is an issue, do paired readings, the last bedtime and this morning's breakfast. Give me some paired readings and then skip a day, for example. That would be my take on it. That's way more valuable to me than a simple fasting blood sugar. And there are many reasons for that, but I'll skip that in the interest of time. Then lastly, if somebody is on multiple shots, a long-acting insulin for the base, and then these bolus insulin for the spikes before the meals. For that, I recommend checking about 4 to 5 times a day. ADA says before meals and bedtime.
Yeah. And so my take is very similar. When I take in the Medicare guidelines and what insurance companies will often pay for basal insulin, most cases they're going to pay for 1 time a day. So whether that's once in the morning or, as Dr. Bhargava said, at bedtime and then morning, but then you have to skip a day so that you're not going too long without strips. And then if somebody is on 2 types of insulin, where they're taking one before each meal and then 1 long-acting insulin, that's going to get 4 times a day strips from Medicare. Most commercial insurances that are paid through what you're doing through work rather than a government funded will be 4 to 5 times per day. So there's a little bit of a difference there. Before we jump into a participant's question, I do have a question if there's any sort of guidance that you have out for the pump patients.
Okay, great question. So people who in pumps are getting the long and short acting, both of them. So in general, the bottom line will work for them. We do like to tweak them a little bit more, and we have the ability to do that. So sometimes I'll have them do a 7-point profile. I'll show that. But most likely, most of my pump patients are already on, a sensor. So sensors are these things which you wear, and they check your sugar in the interstitial fluid, meaning fluid below the skin, and then either transmit or you flash and bring the data to your device, and then you can see these amazing tracing. So in general, pumpers, I'd like to see them on sensors, but if not, 4 to 5 times a day. Thank you for that question.
And then Josh is asking a question. It's on screen right now. He's saying that he can't seem to get his blood sugar down below 180 to 200 after meals. Says that there might be a medicine that's raising his blood sugars. So maybe if we can give him a little bit of guidance on when to take those and check those blood sugars, and what are some goals that he can check before and after meals.
Right. Hey, Josh, thank you for the question. So the important thing is, without having your medication regimen, it's hard for me to recommend what might be going on. But here are a few things. And again, this is no medical advice, just general things to think about. Your meals. Think about how mixed are they? And last week's webinar was on, protein and stuff. So make sure they're mixed meals with, 30 to 45 grams of carbohydrates, enough protein, enough fat. That will really help you out, flatten the peak of your sugars. So that's one thing. Activity. If you are more active around your bigger meals, that's going to help you tremendously as well. So those are 2 things. Thirdly, checking about 2 hours after the start of a meal, because it sometimes might peak at 1, etc. If we want to stay consistent, 2 hours from the start of a meal. Lastly, medication change. And this is seen many times in people on pills. Eventually, pills will stop working. And even people on the second category, the basal insulin only, that they will need mealtime insulin. So one thing you might need is mealtime insulin with the largest meal or with all meals, just depends. But there's one amazing option, these shots. Once a GLP-1 agonist, Victoza, Bydureon, Ozempic, etc. And one of them even came in a pill form. And these are very good for post-meal blood sugar control. So talk to your doctor about that. And please know that wherever you are, we can see still you in Iowa at Iowa Diabetes Care, which is our virtual visits clinic every Wednesday afternoon. So if you want to be seen there, you can. And the information is at iowadiabetes.com, and you can apply from there as well.
Got another question that just popped up from Tessa. She's asking, particularly in pump patients, how can you ease the fear of low blood sugars? For a lot of these patients, they tend to try to make themselves run high for fear of going low.
Yeah. I think fear of low is a big deal. And I've lost patients because of low. I have had patients who are now so afraid that they will keep their blood sugar 200 at bedtime. So it's a real issue. Absolutely, it is. Now, pump patients have a beautiful advantage. Beautiful advantage. So here's the thing. Once I take my Lantus 24 units at bedtime, there's nothing I can do about it. I can't take it out. With a pump, I can do different things. I can do a temp basal, I can do suspend and things like that. And then with the advanced hybrid closed loop system that we have, or the artificial pancreas, and we are researching many of them at our institution, now you can really, the sensor feeds the sugar into the pump and then reduces the pump basal rates. And they are amazing. And also the sensor does alarms. So definitely make sure you have a sensor that does alarm you and a loved one, and then a sensor that guides the pump to reduce the insulin supply going in under the skin. Pumps are awesome for low sugars.
Hey, and it's Casey here. We have another question from Kathy. She wants to know if she's having like a higher fat content, like a peanut butter sandwich. Her blood sugar is high 2 hours after eating. So should she treat that, or should she just let it try to come down on its own?
Yeah, great question. The question Kathy is asking is high fat meal, and in fact, high protein meal. This would happen too. Those things get very slowly converted. So many times, like pizza, it'll be higher for longer duration. What do? Now, if people are on pumps, I'll answer it that way first. If people are on pumps, you can do square wave or dual bolus and so forth. And some of the older pumps, some of the newer ones don't have that. Secondly, you can, if you rebolus 2 hours after, make sure you only do it with the pumps calculator, because it includes the math of what's called insulin on board. And then for people who are on shots only, I would not recommend that, because then you can double dose and have low sugar later on. And again, some of these things are nuanced and are better done in a clinical setting. But talk to your doctor, and again, you can visit us also. All right. Continuing on, thank you for all those questions. This is why we do this. What's on the slides don't matter. We can easily skip those. Your questions are way more valuable for us, so please keep asking. All right. I like simplicity, so what do I tell patients when they're asking? I say a very general thing. Check one more time than the number of insulin shots per day. So no insulin, check once a day about. On one shot of insulin, check twice a day. In 4 shots, check about 5 times a day. Very simple, but that's what I do. I have had many patients who just start checking fasting, like the ADA, and don't check anywhere else. Well, you know every day what it's going to be. So when you are doing them, try to vary the time of the day. And I'm a huge fan of paired readings. And this is a big deal. Like before and after an intervention, before and after meal, before and after exercise, before and after sleep. Those are some good things. Many times my patients who are seeing me from distance and whatever, I'm going to ask them to do a 7-point profile. At a patient from New Mexico recently, I just said, do me a 360, a 7-day, 7-point profile for 3 days in a row. And that's all I needed for helping him out. Before and after meal and bedtime. So there are many ways to do this. And again, there's no one size fits all. It's really based on what you need and what you discuss with your clinician.
Hey, Dr. Bhargava, great question coming in
Sure.
from Kathy, asking what does it mean to have your insulin stack?
Okay. And this slide is perfect for that. So thank you, Kathy, for this answer. So you see what happens is, let's say I'm 132. I took 8 units of insulin. Now I'm 202. I come here and I say, that's high. Dang it, let me take some more insulin. And I take 4 more units. The problem is I did not keep into account the fact that I had already taken 8 units and not all of that worked. It's under the skin, but it has not impacted sugar. So what can happen now when I add 4 more units, I can go low. And that's called stacking of insulin. Good question and perfect timing. I had a slide where I could show it to you. All right, moving on, time check, 1:19, so we are doing good. All right, next thing. I have a question this time. How often do you bring your sugars to your doctors? Rarely, sometimes, most of the times, and always. Those are the choices. Jamie, how often does this happen for your patients? Jamie, you might be on mute or something. For me, it happens most of the times. I'm a glucose Nazi. I mean, I do need to see sugars. You want me to fix your sugars? You want to show me your sugars. You want to go to Best Buy? So I have to go to Best Buy. My phone has low battery. What if I went to Best Buy on Sunday at noon is my appointment and said, hey, can you change the battery of my phone? And they say, okay, let me take your phone. And I said, no, it's sitting on my kitchen counter.
Yep.
What is he going to do? He's just going to look at me and say, are you out of your minds? What are you doing here? So I don't say that I do that, but all I'm saying is, you want your doctor to fix your sugars, please take them. So the right answer is always, most of my patients bring them. And Jamie, what's your thing there? How often does that happen for you in your practice?
So in my practice, I'm somewhere between some of the time and most of the time.
Gotcha. I just have a dozen more years on you, so my patients now know, or they're self-selected, so they just they know that my facial expression will change and tone of voice will change if I don't see the sugars. So.
We've got a question or a comment kind of coming in from, I think it's Liza. So her fiance has an extremely physical job where he's working physically for 12 hours. And he has a sensor, but in the morning, he's still remaining high.
Sure. So again, without all the information, it's hard. And I'm just going to say general things. So if he's so active, most likely he needs less basal through the day. And then during the night, as he's resting and insulin sensitivity goes back to his baseline and not hyped up because of activity, he may be high. So if he's on a pump, he may need a little more insulin. But frankly, without knowing the sugars, because there's three ways people can get high in the mornings. One is they didn't have enough insulin and went up like this. Second is that they had a large meal at supper, didn't check at bedtime, and they were high and they stayed high. And the third is they are too much insulin and rebound. So it's extremely risky for me to hypothesize which one it is. And I think this requires testing either through sensor or bedtime 3 a.m. and morning readings to really know. Great question, guys. Wow, this is great.
We've got another one coming in too.
Yeah.
About Tide Pool and Gluco, and do we use it?
Yeah, great question. So just for our audience, Tide Pool, we have an extremely close partnership over several years. I know the leadership very well, founded in an amazing way. Good heart. People, Howard, sat with President Obama and, talked about what needs to be done. Howard, they're all of them either have diabetes themselves or in the family. We have worked with them. You can upload your sensor and meter through Tide Pool to our platform, Iowa Diabetes Portal. It's really cool. Right now, it's just the meters. In next 3 months, we'll be bringing their sensors also. So it's a great thing. Gluco is a commercial enterprise, more driven by commerce and stuff. They have a lot of capabilities, amazing capabilities, and cover a lot of meters and so forth across the spectrum. So I think they're also worthy of using. We just don't work with them right now.
This might be a really good segue into showing them how we recommend tracking some blood sugars and working with their doctors.
Sure. Yeah. So I think it's so important, not just for your doctor, but for you to know the story of your diabetes and your sugars. You cannot win a battle if you can't see the enemy. How are you going to become the boss of sugars if you don't see them? It's like, hey, my employees are not coming in at all in COVID, and I still am the boss. How am I going to manage, right? So it's for you and for your doctor. Just don't do guesswork. It doesn't help. It really helps your doctor as well. And own your sugars. You are the boss. You can use pen and paper. You can use smartphone apps. And then Iowa Diabetes Portal has the visit optimizer and the glucose tracker. The most important thing you want to always, always, always do. So this is my second issue with sugars. The first one is not taking my iPhone to Best Buy, right? The second one is to do all the effort, but then not write them in the right fashion. When you are checking, it's so important for your doctor to see the trend. So you may not be able to see this very well, but you want to do is you want to have date in the rows and your sugars in different times of the day. And whether you do pen or paper doesn't matter, But whenever you do it like this. And Iowa Diabetes Portal, it's all done beautifully, and I really like it. Maybe partly because it's my child, but also because it really gives me data very easily, different times of the day, and it's pretty easy for people to enter once they are used to it. But yes, it's a lot of work. You can also make notes, and then we can see all of this on our site very easily at Iowa Diabetes Care. We can see them real time, and we can see your comments and stuff like that. But the most beautiful thing is this: we are able to now, a picture is better than 1,000 words, a graph is better than 1,000 sugars. Now it's so easy for me to see this and for you to see this, right? Green is good, red is bad, and orange is still an issue. You see, you're too high before lunch. Hey, are you having a snack mid-morning? Yes, I am. Can we work on that? It's so easy. Your bedtimes are fluctuating a lot. Let's do something about it. So there's so much value our portal gives you. It really is a pain to do the sugars, and that's why we have type pool. By the way, one more thing: we analyze this data and even give you this really cool thing, which patients have used to time their surgeries and so many things. The estimated A1C. If you enter in enough blood sugars, it will tell you estimated A1C, and we get all these meters through type pool. So thank you for asking about type pool, and they're an amazing partner in this fight against diabetes. We really think they're doing an amazing job, and we're happy to be their partners.
I think we have a couple more questions that we can address before we kind of wrap up. Kathy is asking about Levemir and asking, she's been told that Levemir doesn't have any peaks, but she feels like it might be peaking. And is there some sort of recommendation that we can help her about that?
Sure. So Levemir is one of the shorter, long-acting insulins, and depending on the dose, it can last anywhere from 10 to 24 hours. So that's the problem. The insulin that is the longest acting right now in the market is Degludec, and relatively flat and consistent. The Tresiba and Lantus are also becoming flatter. Lantus may still have some peaking in some people. So I don't want to go specifically, but if you find a certain insulin is peaking for you, try a different one. One thing. Second, try a different time of the day. Either one of these two things you have to do with your doctor's advice. Great question. There was a second one, Jamie?
Yeah, there is another one that's just, there's a patient out there, Myra, who's saying that she's on the Freestyle Libre sensor, and she loves that it does some of the graphs and calculations that you were showing that Iowa Diabetes Portal has, that the Libre View is doing that as well.
Yeah. I was telling our team today, many years ago, I was involved in the building of Libre. It gives me immense satisfaction that for several years I advised the company and worked on it. It's an amazing thing, and they've done a great job. So Libre View is pretty cool, and all of these things will show into Iowa Diabetes Portal also sooner or later. Within the next 3 months, I think you should see most of these things in there too. Because what we do is we go beyond glucose and bring it all together for your doctor and for you.
And then the last one is looking at A1C versus time in range, because looking at a time in range might be a new thing that we're paying more attention to now that we have CGMs.
This is beautiful. This is a great audience. So for 5 years, I've been working with Dr. Bergenstahl and Dr. Beck. They've been leading this initiative, and I'm part of that, lucky to be part of that great group of about 30, 40 endos from the nation, Earl Hirsch and many others. I'm just like a fly on the wall in that amazing group. And we've been talking about time in range forever, Dr. Bergenstahl especially. And it becomes more of a reality with these sensors. Here's my story on this. A1C is an average. I'm not very good with swimming. Now, if somebody came to me, I was standing on a river bank, and somebody came to me and said, this river is 4 feet deep on an average, and I'm 5'7". So I said, oh, great. Then, of course, I can cross across. And that's the A1C perspective, right? I will drown. I'll not be found on the other side. That's the same issue with A1C. A1C an average of your 90-day sugars. A time on range is a better thing. We are still learning, and we are going to continue to adopt this. And Dr. Bergenstahl has been championing this AGP, like the EKG of diabetes, and I'm a big fan of his work. And I think you will see that this becomes more and more part of our lingo as we move forward. Hey, we are getting close to the end of our conversation. Those of you who want to hang on, please do hang on. I am not going to let go without
Right.
fulfilling my promise, which is I, of course, want to answer everybody's questions. And I do think we need to talk about how to control my sugars better. So let me take just a couple of minutes to make sure. And again, I'll be here until the last question gets done. And I also want everybody to hear the next exciting webinar we have, Facebook Live. Casey will say, why webinar? No, Facebook Live. So how can I control my sugars better? You have way too many things in your armamentarium to do this. And I talked about some of them. Nutrition, timing your food, how much carbs you have. That's one thing. Activity definitely has a great impact on sugars. Two things, tracking your sugars, number three. Number four, your medications and working very closely with your doctor. Take your sugars to your doctor, insist on having them look at it. Make it so easy for them to look at it. Bring your graphs and just say, even you be your own champion, right? Doc, I see a lot of yellow hair. What can I do about it? You know what you've done for them? You've saved them 5 minutes and they'll be so grateful. And then have that conversation on that graph. Our visit optimizer tool, take it to your doctor's office. It has the graph in it. And show it to them and discuss that. There's so many things you can do in your lifestyle, in your medications, and just have a super strong team, right? Have the team with you, your caregiver, you, your doctor, your educator, your pharmacist. Work with your team. You are playing the game. We are there to help you in this fight against diabetes.
Just to interject just a little bit, I completely agree that tracking your sugars and not just taking your blood sugars, but tracking them and looking to see what happens based on what you've previously done. So check your blood sugar before you eat dinner. Realize what your blood sugar, what you're eating. So let's say you're having pizza, and pizza is high carbs, but also has a lot of high fat in it. And realizing, at bedtime, I'm still high, and realizing that it's the pizza causing it. So it's kind of what's your blood sugar, and then what did I do prior to that? And really understanding what your body is doing because of the activity or the foods that you're eating. And that's your teaching tool to help you learn that control process. And you can do it through like the CGM. If you have a sensor, you can do it through the Libre View. You can do it through Dexcom Clarity. If you don't have those capabilities, you can do it through the My Sugars graph on Iowa Diabetes Home. It's just another tool to help you get the control that you need.
Well, thank you. I like to end our conversations with quotes from people I admire. It is health that is real wealth and not pieces of gold and silver, said by Mahatma Gandhi. He was a nutrition freak. Seriously, he was. I have read his autobiography. He lived his last few decades on fruits and nuts. That's all he did. And maybe vegetables, but that's all. Not even grain. And vegan for sure. So it's a very amazing experiment he did in nutrition. Anyway, our next Facebook Live, Casey, I said webinar, Facebook Live. This time what we want to do is we've collected a bunch of valuable community resources, free and otherwise, and we want to share all of those with you in Iowa. So this will be fantastic. June 3rd, please join, 1 p.m. Central Standard Time. Before I sign off, 3 key takeaways is what I want to talk about. But before that, any questions?
Yes, there's a couple more questions that pop up.
Please.
One again is from Kathy asking, what should you do with your insulin if you're going to have wine with dinner?
Okay. Yeah. So a great question. Alcohol in general, two things to keep in mind. ETOH will eventually get converted in carbs. And more importantly, with ETOH, alcohol, you will consume other high-calorie foods. That's just a general association. And the third thing you need to keep in mind is the alcohol prevents your liver from producing glucose in case your sugar went low. So these are the different things you want to keep in mind. And just know what your body does. In general, I try to tell people, don't drink alone, eat something with it. And just be on the conservative side. Don't get low because your main defense is liver. And if it can't work because of the ethanol then that's not a good thing. So be careful. Allow a little bit higher sugar perhaps at that time then. Next question.
And one last one from Randy asking about an opinion on what you think of LLLT treatment. I had to look this up.
Okay.
I believe he's talking about low-level laser therapy.
I do not know enough today. I'm glad I got a question that I don't know the answer to. I will learn, and we will communicate back through the Facebook thing on this. We'll research and get back to you. Excellent. Well, fantastic. Jamie, your key 3 takeaways that you want your audience to remember.
I want you to talk with your doctor about when you should be testing based on your treatments, what your targets are, and how can you track your blood sugars so that you can learn from them.
Excellent. My 3 key takeaways: diabetes is personal. So should your sugar targets and tracking and all of that. Work very closely with your diabetes team to figure out the right regimen and targets for you, and then work towards those. And we have a lot of tools for you that can help you at the research, at the portal, at our clinic, etc. Well, thank you so much for the amazing questions. You guys did a fantastic job. We are moving to kind of the summer schedule. Things have opened up. We were doing these weekly until now, today, because we had launched this in the Corona time to help our audience and people out with providing value. Knowing that many people have gone to work, we have decided to make it every other week. Summer is coming up. That's another reason why. So we'll do them every 2 weeks going forward. If any of you are still here, please put in the comment section what time works the best for you. We're going to poll our larger audience as well and figure out if evenings is better. We just started this thinking that right now people aren't working, etc. But I think to take it forward, eventually we might move this in July, August to a different time. But please, whatever feedback you give to us will be great. Thank you so much for joining together in our fight against diabetes. Let's change your diabetes together. Thanks.